Now it's my great pleasure to introduce our next speaker, Dr. Mehdi Shishehbor. Dr. Shishehbor is the president of UH Harrington Heart and Vascular Institute and the Angela and James Hambrick Chair in Innovation. Dr. Shishehbor is continuing our theme today of outstanding researchers who are also outstanding clinicians. He was recognized by University Hospitals in 2020 as a distinguished physician for his commitment to patient care. But turning back to his science, Dr. Shishehbor is an internationally recognized expert in minimally invasive approaches to reconstruction of lower extremity arteries to treat critical limb ischemia and prevent amputation. He's the principal investigator of the PROMISE-2 U.S. pivotal clinical trial, which enrolled 105 no-option patients across U.S. centers. The results were actually published last year in the New England Journal of Medicine. He received the 2024 Top 10 Clinical Research Achievement Award from the Clinical Research Forum to recognize these profound contributions to advancing clinical research. And today, he'll share with us his award-winning research study, PROMISE-2.
Thank you.
All right.
Thank you so much, Dr. Thiel, and thank you, Dr. Simon, and the organizers for this kind invitation. It's really an honor to obviously be here. And I'm going to take you to a little bit of a journey today around the work that we have done for over a decade in regards to a condition that affects a significant portion of the patients with diabetes and chronic kidney disease. The condition that I treat is called peripheral artery disease. Many of you may have heard about it. It's typically asymptomatic for majority of the patients. If it becomes symptomatic, it usually presents itself as a lifestyle-limiting claudication. These are patients that when they walk, they get pain in their calf, and when they rest, the pain goes away. So relatively kind of a benign. In the field of cardiac, we say this is like a stable angina, somebody that has a stable blockages and disease in their arteries. When it gets to the more severe form, we call it critical limb ischemia. These are patients that are at risk of losing their limb and getting a major amputation. These are normally or usually are below knee or above knee amputation, which has significant clinical and psychological implication. Now, unfortunately, this disease has not had a lot of advances, unlike some of the other diseases you've been hearing today. It has really struggled. The morbidity and mortality from this disease is enormous, even more than combined breast and urologic and colon cancer from a standpoint of the mortality. 50% mortality within 5 years with CLTI in this population. And fundamentally, the main issue in this condition is lack of perfusion. We don't get enough blood to the tissue, we can't heal the wounds, and patients end up with an amputation. Unfortunately, despite the fact that it has significant morbidity and mortality, there has been little advances in this field. Indeed, in the last 20 years, we have not had any FDA-approved pharmacologic or mechanical interventions for this condition. The only thing we use is really wires and balloon, what we call balloon angioplasty, which is a rudimentary device that we use in the field of interventional cardiology and vascular surgery. So no advances in over 20 years, significant morbidity and mortality. Now, I apologize for putting this picture, and Yi was like, are you sure you want to show this picture? I said, well, these are the patients I see. So I'm sorry, I hope I don't upset anyone, but the reality is that honestly, behind each of these pictures, there is a face and significant psychological, emotional, and lifestyle implication for these patients. I'm proud to say that all of these patients were able to save their limb prior to even what I'm going to discuss with you with our research today. So there's been a lot of technical advances, even though pharmaceutical and technological advances have been limited. Technological advances have allowed us to do a lot. And I wanted to share with you a case that we did here at UH a few years ago. This was an 86-year-old female who came to us with a number of comorbidities and actually had a prior below knee amputation a few years ago, 4 years back. She has type 2 diabetes. And she now came to us with this kind of a picture on the good leg. So one leg is already gone, and she has this leg. And she also, in addition to having necrosis of her toes and having this, what we call dependent rubor, which indicates there is significant ischemia. She had this lesion in her Achilles tendon. So I didn't go showing you all the work that we did, but we are able to treat even patients like this with the current technologies. What the problem is that this condition, the prevalence of CLTI is on the rise. There are more and more patients that we see, and unfortunately, despite all the technical advances and our commitment in saving these limbs, like the patient I just showed you, about 20 to 40% of the patients are still considered no option patients, which means that we cannot even offer them what I just showed you with a previous patient. And these patients end up with a below knee or above knee amputation because we have no opportunity to do a bypass for them because there are no targets in the foot, and endovascular options with wires and balloon angioplasty is not successful because the arteries are so calcified and so occluded that we cannot get down to the feet and get to the tissue to improve perfusion. This cohort of patients, we call them the no option patients. And like I said, majority of them, if not all of them, end up with a major amputation in the United States. And as I've indicated here, over 150,000 amputations happening in the United States. So about 10 years ago, a group of us got together and we said, well, is there a way to try to utilize other veins and arteries in the leg and be able to supply oxygenated blood to these tissues that are at risk and save the limb of these patients? So think of it as like a kind of a traffic jam, and you're able to jump on the other highway and get through the traffic and then get back to where you need to go. So with that kind of a mindset, a group of us got together and we said, you know what, let's do an early feasibility study. Now, this was during the time that the FDA really was not open to early feasibility studies in the United States. But because there was so much limitation here in the United States in regards to CLTI treatment, as I showed you, very few tools in our armamentarium to be able to treat these patients, they allowed us to do this in the United States as an early feasibility study. We were allowed to do 32 patients, 7 sites. UH was one of those 7 in the United States. These were patients that we call no option. Again, they had no option of bypass surgically, and they had no option of endovascularly. And there was a committee that was designed to make sure that that was the fact. So you couldn't just say, oh, there's no option, I'm going to do this procedure. You had to submit the angiograms and all the data. There was a multidisciplinary independent committee that reviewed all the angiogram and all the data, and then they approved whether the patient was no option. And the idea was that, you know, can we assess this concept? Is this concept even feasible? Can we even do these procedures? And if we can't do them, what is the safety of this? How should we select the patients? How do we assess the wounds? How do we follow up these patients? And so on and so forth, in the hope that if this was positive, if there was a reasonable signal, we would proceed to an IDE trial. So this was a group of us. It was a multidisciplinary team of vascular surgeons and cardiologists and interventional radiologists really working together to do this study. And what we showed from the early feasibility study at that time, the 6 months, this is later on obviously, but at that time when the 6 months data came out, we showed that we were able to have a freedom from amputation of 77%. And this was pretty shocking to us because remember, these were patients with no option at risk of major amputation, and we were saying that 2/3 of the time we can at least save their limb by 6 months. And honestly, the side effects were not extensive. There was pain and there was some edema, but there were things that were manageable in this group of patients, and we felt that this was something that we could, you know, take to the next step. So through a series of meetings with the FDA, we decided to design the IDE trial to get this device and this technology approved through the FDA. I was fortunate enough to be the co-PI, national co-PI, with my partner, Dr. Dan Clare, who's a vascular surgeon from Vanderbilt. We had 105 patients that we had sample sized at 20 sites. And the uniqueness of this study was that the population that we studied had never been studied before. Because as you can imagine, when you're trying to study patients, you always want to minimize type 2 error, right? You want to study a very clean sample of patients that have at least going to have good outcomes and are not going to hurt what you're trying to test. In this population, we went after the sickest of the sick. So all of these patients had Rutherford 5 and 6, meaning that they either had tissue loss or gangrene. These were not the claudicants that I showed you in the first pictures. This was not the group of patients with just rest pain. These were people that really had an ulcer and they were at risk of amputation. The second thing is that we allowed dialysis, which have always been excluded from all pharmaceutical and device trials because these patients don't do well historically with any kind of a trial or intervention. The second challenge was that, and we allowed, obviously, this Rutherford 6 is even sicker patients. And as I said earlier, these were no option CLTI. So all the images were sent to a committee that decided that there were no option for these patients. The other challenge was that can we do this as a placebo control? And this was a lot of going back and forth with the FDA in regards to could we have a control arm where we offer them nothing, and basically amputation. And it was honestly felt that, one, we would have a very hard time enrolling patients because by this time, we were already doing this procedure off the shelf, even here at UH. I've been doing these procedures for over 10 years, off the shelf, using devices, putting devices together in some of the patients to try to do this procedure and get blood flow to their feet. So we felt that it would be very difficult to enroll patients. We felt it would be a little bit unethical because there was no other therapy that was reasonable because, again, they were defined as no option patient. So the FDA decided to give us the performance goal kind of a comparison to do this study and have a single arm study rather than a randomized placebo control in this population. And these were the other secondary endpoints, obviously wound healing, Rutherford class, and so on, and pain classification. So the way this procedure works basically is that in our patient with diabetes and chronic kidney disease, they have significant, this is the kneecap right here, they have significant below knee tibial disease. These tibials are 100% blocked, there is significant calcification, and you have to get the blood flow all the way to the toes. As you know, many of the arterial ulcers happen in the distal foot. And if you get the blood flow just to the ankle, it's not going to be enough. So the idea was that can we divert the blood from the proximal portion of these tibial arteries into the venous system? And it turns out that we have a lot of veins in our calf, many, and we could just use one of those veins and enter the vein, put covered stents through the vein, and then divert the blood from the artery into the vein, getting oxygenated blood in a reverse flow format to the feet so that we can heal the tissue. And these are some of the devices, proprietary devices that we use to get this procedure done. These were all the sites that participated. We were one of the sites, obviously, as part of PROMISE 2. And again, no option patients, inclusion of the dialysis patients, and Rutherford 6, which is the latest stage of PAD. These are people with gangrene that need at least a minor amputation, meaning that they're going to lose something. We call them Rutherford 6. So the sickest kind of cohort of patient, this is an example of a desert foot. This is the kind of a foot that was enrolled in the study because there is no target here to bypass, and there was no way to fix this endovascularly. 80% of the patients had already had an attempt at endovascular revascularization in this population. This was the cohort of patients. As I said, many of them have diabetes, almost 80% of them. We were proud of the diversity of the patients that were included in this trial, including African Americans and Latinos in this population. And as I said, about 35% of the patients, a third of the patients had Rutherford 6, which was the end stage of this condition. The technical success from this study, which is a pretty new kind of a procedure, and I'll show you a picture, was 99%. So very appealing and surprising that we could be successful in 99% of the cases. This was the primary endpoint against the performance goal, and we met the criteria for performance goal. So the study was positive from a standpoint of the performance goal. But honestly, I think to me, I think this is what the story is all about. The fact is that we had a 66% amputation-free survival. So amputation-free survival is a freedom from amputation and survival. It's an endpoint that the FDA is very stuck with, even though we never thought that this technology will prolong life per se, but they forced us to use that kind of an endpoint. A lot of these patients, as I said, they die. So we had a number of deaths, and this was during the COVID era. So we lost about 4 or 5 patients because of COVID. In any case, we had 66% amputation-free survival, a 76% limb salvage rate, and an 87% survival rate in this study. This was a subgroup analysis. as you can see, aside from dialysis, almost everybody did better with the DVA, deep venous arterization, in this cohort. And the conclusion of the trial was that obviously the trial met its primary endpoint. It was effective and safe. It was 99% technically successful, at least at these 20 sites, and 76% of the patients had limb salvage at 6 months. I'm proud to say that we are now just submitted the 2-year follow-up, actually, of this trial for publication, and we have a 74% limb salvage survival or freedom from amputation at 2 years. So there's sustainability beyond 6 months with this technology and this kind of intervention. And just to share with you one example quickly, I think I'm going over time, I'm sorry. This was one of the patients that we enrolled here at UH as part of the PROMISE 2. She was a 73-year-old female with the Rutherford 5-6. You can see the ulcers here in her foot. She had multiple comorbidity, which is the kind of population that we get in these studies. And as you can see here from the angiograms of the ankle and the foot, there's really no arteries here in the foot. You see here, this is the right below the knee, this is the anterior tibial. This is what we call the tibioperoneal trunk. There's one artery here that ends here in the mid-calf, and then there is nothing really in the foot here for bypass or for a stent. So this was a patient that we bring in. So what's unique about this trial is that we have to get access in these patients in the bottom of the foot. And that's something we've never done in our field. So this is there's some unique nuances about this procedure that we had to learn, and we are able to get access. This was done many years ago, and we're able to get access. We are able to bring our wires up the vein, down the artery, have them meet each other and connect. And then through this process, we can create this kind of a blood flow to the foot. So now we are able to bring the blood here from the artery, divert it into the vein. This is the vein now on the bottom. And we get this kind of a perfusion down to the foot. This is usually what happens after the procedure. The next day is a lot of ischemia because you're stealing the blood from the foot, from the native arteries, and take it to these venules, which are not yet been arterialized. So we see this kind of a worsening of the symptoms, pain for about 3 to 4 weeks. But then this is the happy moment when we are able to heal the foot. And this is a patient actually that we've done now for a few years, and she continues to walk. She has not had any recurrence of the wounds, and she's doing fantastic. Thank you so much. This was published in New England, and we got FDA approval last year, as Dr. Thiel mentioned. This was the first device to get FDA approval for CLTI ever. There's not been another device or pharmaceutical drug that has ever been approved for this condition. Thank you.
Thank you so much, Mehdi. That was fantastic. Can you tell me about the uptake and adoption of this technique nationally, internationally at this point?
Yes, so we have done now 2 trials, one in Asia that has also shown similar outcome and is now been approved in Asia. And also in UK, we did a similar trial that also showed similar limb salvage rate. So it's also been approved in Europe, is available. As I said, is FDA approved here in the United States. It currently has a NTAP, through CMS. So it's commercially available across the United States. We have it here commercially. We're also pursuing additional research in this area. So we are involved with the PROMISE 3, which is trying to understand more about the patient selection and other features of this technology as we offer them to our patients.
So we actually do have a couple of minutes if you wanted to give us a hint about PROMISE 3. I think we'd love to hear about it.
So yes, there are a couple of areas that we are pursuing as it relates to this technology. One is that, can this technology serve as an adjunctive therapy for even lower risk patients? Because remember, up to now, we have been studying this for no option patients, people that have no option. And a lot of us feel that this is really end stage. And these patients not only have significant vascular disease, but also have a lot of comorbidities that any device or any operation in them is not going to have the best outcome. And given how safe this technology has been so far, based on our experience here in the United States and abroad, as I mentioned, is that should we be offering this kind of technology to people that maybe have a compromised blood flow, but not this extreme, that they are not no option, but they are in a stage of compromise, meaning that they are not the lowest risk people that we can just bypass or easily fix and get significant blood flow for them, but they are in the middle between no option and that cohort. So we are in communication with FDA and with the various organizations to see if we can put a trial together to see if we can move the needle a little bit more downstream for patients that are in the middle between no option and lower risk.
Yes.
Thank you, Dr. Shishehbor, for the fantastic presentation. My name is Omid Haji Asani from Department of Surgery. My question goes back to the field that I work in, that's cancer. One thing that we know about tumors is the environment they create because of the low perfusion, and that environment neutralizes many macrophages, a lot of immune suppression, and then help the growth of the tumor. Is it possible to apply a similar approach with the perfusion to tumors in different locations in the body and deliver drugs better and have a better perfusion in the system?
Yeah, it's actually a great point. Honestly, you know, and again, I'm not an expert in cancer, but I think from a standpoint of perfusion, I think this has opened eyes for us in a sense that we can utilize other blood vessels to get oxygenated blood or perfusion to areas that there is a lack of perfusion. And we are actually also doing some research right now in the arm for patients that have ischemic hand. So there is some communication and discussion in regards to selective patients that have ischemic hand. These are also diabetic patients and maybe a scleroderma, some other conditions. So I would say that there may be other utility of this technology for other areas where you want to have more blood flow to be able to get drugs or therapies to that segment.
Right. Dan?
Yeah, I just wanted to make a comment that it's really nice to be here now that we can lead in research in the U.S. and nationally and internationally. And last year, Mehdi Shishehbor and Amru Siraj, I nominated them for something called the Clinical Research Forum Award, which is that every dean is allowed to nominate 4 people. So there are about 400 nominated in the U.S. UH nominated 2. The dean accepted our nominations. And Mehdi Shishehbor and Amru Siraj were awarded top 10 in the United States. So that's very exciting and should be very inspiring to see that you can come up with this simple concept. If the road is blocked, can I take another road? Here, the road happened to be a vein. So congratulations, Mehdi.
Thank you. Dan, I want to throw it right back at you, Dan. Thank you for all of your support with research. We know that what makes us unique. We know that research is hope. You always say this. And it's really what brings us to work, because if it's not for the research and the science and the impact that we can make on these patients, it's really sometimes hard to come to work in this era of healthcare. So thank you.
Yeah. And I think Dr. Technos?
Yes, Mehdi, obviously fantastic work. Congratulations. You know, the other hat I wear is a microvascular surgeon, and reversing flow in a vein is fraught with disaster because you have valves, and the valves block flow when it goes antegrade. So how do you overcome that in the foot? I know you talk about, you know, stripping the valves out of the main veins, but then in the foot, you know, how do you overcome it? Because you can't strip the valves all the way down to the distal venules. And then the second question is the pain that you're experiencing just, you know, the alternative veins learning how to return blood to the foot? Because what's the venous outflow then if you're using the veins for arterialization?
Great questions, Ted, and thank you. Actually, you hit on a nail even in another aspect, which let me address first, which is the microcirculation. So we have been saying for years that, you know, PAD and CLTI and this condition is a macrovascular and a microvascular disease. We have balloons and stents for the macrovascular, but we have had significant limitation in microvascular. As you know, there's been a number of biologics that have been studied, and I see Dr. Stamler also there. There's been a number of biologic studies of various form to try to improve microperfusion to the foot. Unfortunately, we have not been successful. Interestingly enough, I think this has been a very unique way to improve microperfusion in a reverse way through the venules into the foot. Now, you raised a good question. So we can address, and you're right, the bigger veins, in the calf, and even some of the veins in the foot, not the venules, but in the foot, we do go in there and we do have valvotomy devices, and we damage and destroy those bigger valves in the calf and in the foot. But because of the so many tributaries, and we don't really, and we think because of the pressure, those valves, those venules, those valves become dysfunctional because the arterial pressure is so much higher when it gets to that level of the capillary bed. And at that level, that it just opens up, there's so much dilation that the blood is able to get through. And that's why we think that it takes a little bit of time. It takes about 3 to 6 weeks for that maturation to happen, because for that dilation to happen, to allow the oxygenated blood and the arterial blood to get through the venules, the small veins, and to get to the capillary bed takes time. And we think that what's dealing with those valves, those smaller valves that we cannot get to, is that pressure, that arterialized pressure that's coming that they're not used to, which allows the dilatation and makes the valve basically dysfunctional. There's no more coaptation and allows the blood to go through. And when we take a picture, it's interesting, and I didn't get into it in this presentation, but when we take pictures of these patients 3 months, 6 months later, it's amazing. The arterialization of the foot is just incredible. We never see that when we work on the arterial side. So there is a lot of recruitment, if you will, of the capillary bed and a lot of arterialization of the venules. Regarding the veins and, the fact that we use one of them and so on and so forth, as you know, each of the tibial arteries have 2 veins that run by them. So we have 6 tibial veins. We have the small saphenous vein, we have the greater saphenous vein, we have the lesser saphenous vein. So actually one of the main concerns we had with this condition was that would there be a lot of edema in the foot? And we haven't really seen that. The pain is real, and we think the pain has to do with that maturation, but also from steel, because we are really competing with the native blood flow by creating this system, and we take some time for that maturation to happen. And during that time, we typically treat this patient with narcotics while they get that maturation, and the pain goes away.
Thank you so much.
Thank you.
Dr. Shishehbor. That was fantastic. Thank you.